So I gather you've got some clinical decisions as well that you want to talk about. Let's dive into those.
Is there an age limit which you won't treat with Botox? And obviously legally it's 18, but is there a lower age limit where you'll say you're under 25, I don't want to be treating you at this age because we risk resistance, the Botox potency lessens with time? Is there a lower age limit that you won't treat?
So I think that age is one factor that you might take into account. The true way that a proper medical decision is made is that it's based wholly around the individual that you're in front of. So I don't like anything that's a blanket decision. And, I've never treated someone less than 18, for example, even before it was illegal. But I actually think if they'd regulated this around medical practitioners, that law would not be needed, because the medical way of decision making is that you would have to justify that intervention, that is in the best interests of the patient. So in my GP practice, I can prescribe the pill to a 12-year-old. It doesn't get that more controversial than that. But I can't treat an 18-year-old with 17-and-a-half-year-old with Botox. And I think, although I've never had this indication, there probably are some people who you could argue would have a really good benefit from it. Like maybe master reduction. So they've actually got something that's actually different, that's causing them frustration and trauma at school. They might be getting bullied over something. If it's dramatic enough, you could argue that it was in their interest to change it. But now I no longer have that option as a doctor. And that is only because that was an easier thing to do than to regulate the whole industry to make it medical. Because a medical doctor does all sorts of things that are, for the right patient, wrong for everyone else, if you know what I mean, but could be right for that patient. So I try and think that way around it. The numbers to know are older than 65, you're off label. So all the data is around patients that are younger than that. Younger than 18, we can't do it anyway. The typical 21-year-old probably doesn't need it. There's nothing distracting. But there are people who have hyperdynamic muscles I have been asked for a treatment by a 15-year-old in a salon who had forehead lines, horizontal forehead lines. So she clearly had lines on her forehead that I didn't have at that age, even without Botox. I had not developed. You could argue that that would be the kind of case that might be in certain circumstances worth it. But the point is, although she was never treated, you'll have the same when she's 21. And I wouldn't have a rule. I'd look at each patient and say, do they have lines at rest? So I'm not a big fan of using Botox as a preventative for someone who has no lines.
Yeah, the baby Botox. I've heard this sort of term thrown about.
That's just a marketing term. It's what we call a communication innovation. You communicate the same thing in a different way. So let's just put less in and give it a new brand. And then people who want less will have it. And then most of them actually end up having more over time. You're designing around the individual. You'll meet it's an 18-year-old with deep lines one day who needs a full dose treatment. And if you just blanket a no for everyone, that could cause you an issue. One of the reasons you might do it, though, is because if you think there's a reputational risk. So because we're not purely public health, if you think that in your neighborhood, if there are for some reason, lots of 18-year-olds who seem to have deep frown lines and you've treated them all and everyone's they don't see the before, they only see the after and they don't understand it, then you could make the argument that you'd rather not. But that's the only reason I could think of not doing it, other than just treating the patient in front of you.
Yeah. Take every patient, every patient's story.
Yeah.
And take into account their holistic health.
Yeah, and how it's affecting them. I can't stop frowning. Everyone thinks I'm pissed off, but I'm not.
Yeah, I've got a rest of bitch face, yeah.
Okay, well, you can have a treatment. I'm 25. I've got no lines at all, but I just want to stop any lines developing. I don't think you should have a treatment, because you might do that for 10 years before you get a line. You'd rather put it into your mortgage,
Yeah, it's a waste of money.
Because some people get into their head that they have to do this or their face is going to fall apart. And that's not true. You can wait for the lines to develop. And if they're only little, they'll disappear in 2 weeks.
And patients will appreciate you being honest, won't they?
Yeah.
And that comes across.
Just to encourage this even more, I've got so many patients by saying a flat no to people who then feel so amazed that someone actually didn't just treat them, that they actually refer patients to you.
Yeah, you're not just money grabbing, are you?
Yeah. It's a long-term game.
Yeah. Just another question with Botox. So if I'm using the normal Botox brand and if I'm getting great results for patients over time, do you change to a different brand to prevent the resistance of that ever happening? Or if you're getting good results, do you just keep going?
I would normally just continue. I wouldn't switch it. It kind of complicates things. Resistance, I don't think it's that well understood. They say the incidence is very low, so it doesn't actually happen as often as people fear, but it definitely happens. And I've had people who think it's very low disagreeing with me. I'm I literally have 4 patients who I've been through every brand of Botox with, and none of them work, and they cry. Like, it's not like I'm not trying. And yes, you can put the dose up a bit, but there comes a point where you're using so much that you've got to explain that somehow, and they never used to use so much. So then you have to leave a much longer space or do other treatments. It's definitely a thing. I think it's more likely in people who have much more regular follow-ups. So there are certain people who come for every follow-up. They always come for additional treatment. They come, as soon as they can, and they try harder and harder, and eventually it basically stops.
Do you book them patients in for, because what I'm doing at the moment is I'm booking patients back in for the follow-up. Do you manually book them, or like at first did you? Or because I've sort of booked them in because I want the before and after photos. But once I've sort of got a lot of them, should I be booking them in myself? Should I let them come back? I don't know.
So in the beginning, I think it's a really good idea for you to see everyone back, because you get a ton of learning. You get to get them into the habit of seeing you. You will, you can see what individual injections, especially if you take pictures with the markings, and then you see what you've done. That will speed up your learning faster than anything else that you can do. So it's really worth it. In the long run, it can become not worth it, because you will be training them to come back multiple times. You tend to do a little adjustment here and there.
They expect to top up, don't they?
Yeah, and unless you are very focused in making sure that it's just a check and that you don't need to have an injection and we've done the right job, you can end up in a dynamic where you're spending a lot of time and money on a lot of patients that don't really need to be seen. I would do it for a while and then try and switch away from that and train. Our typical follow-up rate was about 15%, to give you an idea. So 15% of people would have an adjustment. And it could probably be lower than that.
Yeah, I think just once you get confident with your injection patterns and you know that they shouldn't need a review, then maybe don't manually book them.
And if they've come back, you've got a picture of the original treatment, and then you do a top-up, you then know what you can do on the next treatment safely. And once they understand that, they should understand why they don't need to come back as well. But in the beginning, it's good to see them back and ask them that question of how's it affected you? How's life been since it? Because then you can better understand how these treatments actually affect.
Not just the lines, but actually the whole of the person, yeah. Another question is, so with numbing creams, I just use the LMX, and I've seen some of these crazy numbing creams going around. They're quite unsafe, aren't they?
So there is an issue with lidocaine toxicity. So if you do the maths on it, in terms of how much can be harmful for you, a lot of them can tip into that quite easily. So obviously it's very tempting, because the theory is, we'll just completely stop all the pain with this.
Yeah, and I feel bad for clients, so I feel like if I could help them in any way to get a higher numbing cream, but then I've heard that it's dangerous.
Yeah, I think you can, especially with this sort of 50% stuff, if you I haven't got the maths with me now, but if you work out percentage-wise how strong it is and how much it would take, it's actually not that much if they were to get it into their mouth before they get some symptoms from it. It's not insanely dangerous, like otherwise I don't think it would exist at all, but it's definitely on that spectrum of, if you go a little bit too hard on it, then it's
so don't risk it.
Cardiac problems and various other, and it does happen. I think 4% applied enough times, while you're doing other things.
Give it time to work.
Similar.
Yeah. And if you're doing injections to the bone, like on the cheekbones, how much difference does numbing cream really make?
So it makes a difference to the entry point, because that's where most of the sensation is. Otherwise, if you're where the nerves are on the bone, you don't get much benefit at all. So the best example of that is probably a nasolabial fold, where your infraorbital nerve will come down and supply the top lip. So if you do on the periosteum injection there, they often feel that. And then they also get numbing result as you inject the filler with lidocaine in there, their top lip goes numb. Cheeks, you might hit a nerve occasionally, but it's less likely to. And so most of the benefit is probably with the skin.
Just the literal first bit of injection, yeah.
Yeah, but you're right. It doesn't help much underneath the layers of the skin.
But maybe it's a bit more of a placebo, that the patient might feel better because they've got numbing cream on. So
that definitely helps.
If that helps them, then it's worth it.
Here's a cheeky tip. Very anxious patient who's having multiple areas treated, but not having their lips done. I will often, when I'm putting the cream on, just skim the corner of their lip. And it works like magic. They go, that cream really works, doesn't it?
Yeah.
And like, yes, it does. It does really work.
Yeah, just get it into the head that it works, yeah.
And that just puts them in a frame of mind of thinking it's not going to be bad, because it's mainly psychological. Like a lot of the pain with injections, I'm not saying all of it, but for me as a person being injected, I used to have a bit of a needle phobia. And I remember the first time I had Botox, Dr. Saba treated me. She did not enjoy it because I was a very anxious patient. But it was all in my head, because once I'd done it once, like, it's nothing really.
Yeah, it's fine, but just the psychological part of it, isn't it? Yeah.